going, or still got few more?
Okay, I will introduce the prevalence of these two diseases. Basically, prevalence is the proportions of populations who have specific characteristics in a given times. For prevalence of ischemic heart disease, or we call IHD, estimated that IHD globally affect around 126 million individuals, that approximately 1.72% of the world's populations. With that, 9 million deaths were caused by IHD, and show men were commonly affected than women. The IHD prevalence is rising this year. Then, for prevalence of acute coronary syndromes, or we call ACS, out of 300 patients are diagnosed with acute coronary syndrome had unstable angina with 37.7%, and NSTEMI with 36.7%, while 25.7% for STEMI, that show male more significant affected than female. The prevalence of older populations for ACS is higher due to risk factors like hypertension, diabetes mellitus, and hypercholesterolemia. Next. Okay, we go to the definitions of
Sorry,
SQ.
I'm just going to interrupt you. Going back to one slide before the prevalent part. Okay, just wondering, have anyone heard about National Cardiovascular Database, NCBD? Okay, so actually for Malaysia, we have our own data, and this actually quite established data that they've been doing almost every year, and this is what we call NCBD lah. So NCBD actually is they always release every year, but now I think they release for maybe 3 years back. So data from 3 years back, looking in terms of the prevalence and incidence lah. So I think we won't question you in terms of prevalence and everything. Just good to know if you have a free times, maybe just have a look lah about NCBD. Okay, okay, proceed.
Okay, next, we go to the definitions for ischemic heart disease and acute coronary syndrome. Okay, ischemic heart disease is a typical heart disease that occur when there is a reduction or obstructions blood supply to the heart muscle due to fatty depositions in coronary arteries that called atherosclerosis. Acute coronary syndrome consists of three disease process, which are unstable angina, ST elevations myocardial infarction STEMI, and non-ST elevations myocardial infarction and STEMI. For the unstable angina, it is a chest pain that occur at rest, and it is more severe, prolonged, and frequent than typical angina. This associated with plaque formations that result in cardiac tissue hypoxia. For STEMI, occur with rupture of atherosclerotic plaque that partially occlude coronary blood flow, result in cardiac tissue ischemia. There is no persistent ST segment elevation on ECG for STEMI. Conversely, for STEMI, developed from the rupture of the plaque that cause acute complete obstruction in coronary blood flow that result in myocardial tissue necrosis. There is elevation of ST segment on ECG for STEMI. Next I will pass to the next presenter.
Okay, Assalamualaikum. So I will present to you about sign and symptom. Next. For the symptom ischemic heart disease, first, patient may present with central chest pain or breathlessness during exercise or activity. Furthermore, in patient with heart attack, the chest pain may be sudden and quite severe, and will associated with sweating, nausea, palpitation, and giddiness. In certain conditions like diabetes and old age, the symptom may be mild, absent, or atypical, which is they may present with pain in the stomach area. Next. For the sign ischemic heart disease, the patient will experience chest pain or discomfort. Secondly, they will got shortness of breath, which is difficulty breathing or catching your breath, especially during physical activity. Lastly, they may experience arrhythmia, which is irregular heartbeat or a rapid pounding heartbeat. For the symptom acute coronary syndrome, first, the patient will experience palpitation and chest pain. The pain will occur at the same site as angina, and the people will experiencing pain like pressure, squeezing, or burning across the precordium. This pain may radiate to the neck, shoulder, jaw, back, upper abdomen, or arm. This radiation known as referred pain due to the nerve branches send signal to the same brain cell. For the third symptom is exertional dyspnea, which is difficulty to breathe at rest. Fourth, diaphoresis or excessive sweating. Fifth, the patient will experience nausea, pallor, and decreased exercise tolerance. For the sign acute coronary syndrome, the patient will have hypotension, which is indicate ventricular dysfunction due to myocardial ischemia, myocardial infarction, or acute valvular dysfunction. Second, diaphoresis, which is excessive sweating. Third, pulmonary edema. Fourth, extracardiac vascular disease. Fifth, jugular venous distension or raised jugular venous pressure. Next, cool clammy skin and diaphoresis in patient with cardiogenic shock. Uh, third, third heart sound, and frequently fourth heart sound. The heart sound is extra heart sound that occurs soon after the normal to luk-duk heart sound. Um, and next, a systolic murmur related to dynamic obstruction of the left ventricular outflow tract. And lastly, rails on pulmonary examination. I will pass to the next person.
So for the next is investigation. Next slide, please. So for the investigation, we can do through ECG, where the unstable angina, we can look the ECG is normal and there is a possible in ST depression. While the NSTEMI, there is ST depression and it can also be normal, but there is a possible T wave inversion. For the STEMI, there is ST elevation and hyperacute T wave. For the next investigation, we can do blood tests through full blood count, urea and electrolyte, or cardiac biomarker such as creatine kinase or troponin. It is good to know why we need to do cardiac biomarker because in ACS there is a cardiomyocyte injury where our heart muscle is damaged, and when there is a damage, this troponin will leak into our bloodstream. So that's why we can detect the troponin level in our bloodstream, such as unstable angina. We can see it is normal troponin because there is not damage yet while the NSTMI and STEMI it already damaged, but the difference is the N is partially, but the STMI is completely damaged. So that's why we can detect the risk troponin. Next slide, please. So the next version we can check through chest X-ray to look for pulmonary edema and to rule out other non-ischemic condition causing chest pain like pneumothorax, aortic dissection, or pulmonary embolism. We can also do echocardiography to look for regional wall motion abnormality like hypokinetic or akinetic area, uh, meaning that we can see where the area in our heart that is lessly contract or not contract and not contract at all. And we want to look for ejection fraction or look for other complication like septum rupture, chordal tendinous rupture post-infarct, and heart failure. Next, please. Okay, we go to management. Next. So, ACS management, we need to treat it immediately by giving antiplatelet like aspirin or clopidogrel. If the patient's oxygen is saturated below 95%, we need to give it and we give them extra oxygen. And we also can give them glycerin trinitrate, GTN, sublingual tablet, or we can give it IV morphine as analgesic and IV metoclopramide. Next. So this stratification in unstable angina and SMI, we can detect it through several score. The first is TIMI score and Gray score. So do you know what is TIMI Gray score? So TIMI score is short form for thrombolysis in myocardial infarction. It is used to determine the likelihood of ischemic event or mortality in patient with unstable angina and the NSTMI. Senang cerita, dia lebih kurang untuk tahu berapa kerap event untuk terjadinya ischemic heart disease ni. So like the table below that, there is several risk factor. So if the patient age above 65, we can score it as 1. And if the patient used aspirin in the last 7 days, we score it 1. So when we total up the score, we can know the rate of death or myocardial infarction in 14 days. Or we can know the rate of death or urgent revascularization. So for Grace score, it is a tool to help clinician to assess the future risk of death or myocardial infarction and also to guide to the treatment option. So there is several that we need to depend based on age, heart rate, systolic blood pressure, serum creatinine, and the CLIP score. The CLIP score can be categorized into 4. The first one is no crackle and no third heart sound. The second one is crackles in below 50% of lung field or a third heart sound. And the third one is crackle in above 50% of lung field. And the last one is cardiogenic shock. Next. So patient with unstable angina or NSTMI should be given like if the low risk patient, like I mentioned it earlier, we can give it antiplatelet, anti-ischemic agent, and anticoagulation. Why we need to give this drug? Because we want to prevent the spontaneous clotting like blood clot, so that we do not want to give it more severe. And for high risk patient, in the presence of ongoing chest pain or hemodynamic instability, the urgent coronary angiography will need to be done to revasculation. Revascularization should be considered if the facility are available. Next. So, STMI management. So, there is a note. Time is muscle. So, do you know what is time is muscle? Basically, time is muscle is meaning that the longer we wait to get the patient in for treatment, there are more damage that can occur to the heart muscle and less likely chance for recovery. Maksudnya, lambat kita bertindak untuk bagi treatment, lagi tinggi possible untuk jantung tu untuk damage. And kuranglah chance untuk jantung tu recover balik. So, we can do reperforation through PCI or thrombolysis. PCI is percutaneous coronary intervention. Where the clinician will do open the blocked artery through non-surgical method, such as the clinician will do stent or balloon inserted. And the second one is thrombolysis. We can give some drug like streptokinase, alteplase, or tenecteplase. This drug will lysine or dissolve the thrombus or clot and achieving the reprobation so that the blood flow can easily flow like smooth sailing. Next. Okay. I think that's all. Thank you.
Okay boleh dengar kan? Semua boleh dengar Boleh dengar ke?
Boleh ada.
Soalan, ada soalan tak? Boleh nampak tak my slide?
Boleh.
Boleh Nampak the whole slide ke macam mana? Okay, nampak ke first page?
Nampak ada.
Okay Okay lah. Overall, okay. In terms of presentation tu, I think no issues. Just to tidy up a bit lah. Okay. Because I think for ACS, for ischemic heart disease, there are actually a few key points that I would like you guys to appreciate and understand lah. Okay. So the first thing, I think the main thing is just more definition. I think you guys covered that quite well. It's just that definition too, why is important because for you guys to appreciate in terms of the pathophysiology. So far, I think you guys already outlined the definition, right? But then again, how is it different in terms of pathophysio? That's the other thing I would like to highlight lah. Because if you look at a spectrum, unstable angina is mild. Okay. So unstable angina comparing to STEMI. STEMI is the other spectrum lah. So when they have a STEMI, which means they have total occlusions. That's why they have thrombus. Or if they don't have any thrombus, maybe we're looking at the unstable angina. If they already have mild thrombus, they might living with non-STEMI. So nonetheless, we can divide into two lah. If they have total occlusions, then STEMI. If non-total occlusion, then either be unstable angina or non-STEMI. Okay. So that's the first key point lah for everyone I would like to appreciate. And okay. Okay. Boleh dengar? Can follow Boleh ke?
Boleh.
Okay. That's the first point. The second point actually is more toward how is it different in terms of symptoms. So far we already go about pathophysio. So now we are going to cover a bit about symptoms, symptom and signs. So symptom and sign, I think you guys already presented what symptom, what will be the symptom, chest pain, palpitation, and all other things. But the other thing I would like you guys to appreciate is to differentiate between typical, atypical, and non-cardiac pain. So if you're thinking about typical, then that's when you have a central chest pain, associated with stress or positions lasted for 2 minutes. That's why other symptoms. That's when they can have diaphoretic, nausea, sweating, and even palpitations. And sometimes they might resolve with rest. So when they have these kind of symptoms, is chest pain, congestion, relief by resting, then we dealing with typical symptoms. But if they don't have any those kind of symptoms, we might dealing with atypical. For example, they can have epigastric pain, they can have just back pain, they can have just a sweating. So that's those can be atypical chest pain. But the things that I would like to highlight, if they're totally non really cardiac pain, for example, they can have like pleuritic chest pain. Pleuritic chest pain, which means that when they take a deep breath in, that's when they can have a sharp pain. So when you have pleuritic chest pain, most of the time is either due to the lung or it can be due to pericarditis lah. So those kind of things can assist you in terms of the prevention to chest pain lah. Okay. So during exams, usually what we tend to ask actually is not really not really these kind of pictures. For example, we can ask you, patients are 70 years old, came with pleuritic chest pain. What will be your diagnosis? Something like that. Patient 55 years old came with shortness of breath, failure symptoms. So what could be your symptoms? What could be your diagnosis? Something like that lah. Okay. Okay. So I think there's another thing I forgot to highlight, which is the risk factor lah. Because I think the risk factor we can divide into modifiable. This is the risk factor like smoking, things that we can modify, we can control, and we can educate the patients. And for non-modifiable, unfortunately, I think you already mentioned age and also male, especially it's more common in female. Okay, and this is the things that maybe worthwhile knowing that chest pain. When you talk about chest pain, it not 100% it can be cardiac. It can be due to other things like it can be due to pulmonary embolism, pneumothorax, or even musculoskeletal, or it can be just GI related. But nonetheless, when we have a chest pain, this is the thing that we tend to think and we tend to rule out. Okay. I think so. This is just going to give a case scenario lah. Okay. And how do you take history lah from symptom when patient having chest pain? So usually we tend to go to my mnemonic tend to go to WWQQAAB. But I think for UIA they have their own mnemonic which is Socrates. But have anyone heard about that mnemonic? Socrates. Pernah dengar tak?
Pernah dah.
Pernah. Okay, so Socrates 2, I think just I'm not sure whether you're going to be asked for that or not, but I don't think we're going to. Nanti during exam ada tak OSCE? Okay, OSCE session for medical. I think ada got kan? But I think for you guys will be unmanned, which means that we just put one stamp and then you just look at the stamp and then answer. Betul tak? Yeah? Okay. Tak apa. So, nonetheless, I think just follow ni lah. Betul lah. Take history lah, Socrates lah. Okay? Investigations. Okay. So, I think you guys already mentioned about a few investigations, which is quite thoroughly done. The things I would like to highlight is just the difference, what you can do from bedside. When you talk about bedside, you always talk about ECG lah. Okay? And blood test, you always talk about cardiac enzymes, either troponin, and imaging. Most of the time we tend to go for echo, and then if needed, then further invasive tests such as angiography. The reason we want to do investigation is to differentiate whether is it fall into unstable angina, or is it non-STEMI, or even high end, which is STEMI. So nonetheless, the first difference will be troponin. It will be raised for non-STEMI and STEMI, but for unstable angina it will be normal. ECG can be normal, but for STEMI, they can have ST elevation. Okay. So this one, I think we won't ask you in details or even we will emphasize in exam just to share a bit about ECG, because I think we tend to ask ECG not frequently. I don't think we're going to ask ECG, but just to highlight that there's a P wave, PR interval, QRS, ST, and T wave. So when we talk about STEMI or non-STEMI, we look at these ST changes. Okay. Because ST changes is actually present what happened in the ventricular. Usually they have a J point. If it's elevations, which means they tend to have a transmural infarction or complete occlusion. That's when they can have ST elevations. Okay, but if they have ST depressions, that means there's evidence of ischemia. And when they have a ST changes, first they will have a happy QT wave. and that's why they can have ST elevations. So this is showing the ST elevations. And non-STEMI, sometimes they can have ST depressions or even TU elevation lah. Okay, so that's the difference between STEMI and non-STEMI in terms of ECG changes. Okay, in terms of management, I think you guys already covered quite well. But just to highlight, in terms of management, we can divide into acute and chronic lah. For example, if the STEM is patient came with chest pain, ECG, ST elevations, what will be management? So your management, you can divide into acute management. If acute management, then ABCD lah. You give oxygens. If SpO2 is less than 95, B, inotroph, fluid, okay, everything. Okay. But if it's non-specific management, if it's acute management, again, painkillers, morphine, oxygens, nitrate, and specific management will be aspirin. And this is all the specific management, either for unstable angina or non-STEMI, Clexane, anticoagulations. If you answer anticoagulation, you already got marks. Okay. But if you want to be more accurate or more emphasized or more specific, you can put Fondaparinux or enoxaparin. Okay. But if you answer anticoagulation, you already got marks. And then antiplatelet. Antiplatelet is aspirin plus clopidogrel. And then the other medication is actually is just to just to highlight. Okay. I think you already emphasized time in muscles because I think this is the one that is really important. And long-term management, usually this is the medication that your patient will be on, beta blocker, ACE inhibitor, statin. So when we talk about management, we have acute management, which is aspirin, clopidogrel, anticoagulations, morphine, analgesia, oxygen if needed. Okay. But if long-term management, which means patient already on treated acutely, so medication will be beta blocker, ACE inhibitor, statin. Okay. Another thing maybe worthwhile to know actually is complications. When we talk about complication, again, we can divide into early and late. Early can be cardiogenic shock, heart failure. But if you late with that, when we talk about valvular regurgitation like mitral regurg, aneurysm, cardiac tamponade, or Dressel syndrome. Okay. I think this one I will skip that. Skip that. Okay. So I think this among all the slide, I think you guys already quite familiar with management. I think the management you can read on the textbook and it's going to be similar. But another thing I would like to highlight actually is now from 2017, we already have a difference in terms of management because now management not just looking at the in term of spectrum, we're also looking at the timing. For example, if patient came at a PCI center within they're able to do it within 60 minutes, then they have to give PCI. And then if not, then they have to give lytic lah. So lytic tu usually I think everyone aware lah, there's STEMI actually due to the blockage. And when we talk about PCI, that's when we're talking about to open up the narrow artery so that we can put a wire in, put a stent in lah. Okay. And if unable to proceed with angioplasty, then we proceed with lytic, which means we give tenetoclax or streptokinase. Okay. I think okay. So far ada soalan tak? Any questions?
No, doctor.
Tak ada. Because I think for exam purposes, I don't think we're going to ask a lot more details lah. We're going to ask more a bit superficial. I think the key home messages or the takeaway home messages actually is to look at a few points lah. First, I think you guys need to appreciate the definitions of ACS, whether is it non-STEMI, STEMI, or STEMIGENA. So you need to appreciate that. And in order to appreciate that, you have to look at what features to distinguish between those three. Either symptoms, for example, symptoms lasted more than 20 minutes, is it organizations, is it really by resting, and those are the symptoms that differentiate between non-STEMI, STEMI versus STEMIGENA. Okay, that's one. And to look at the pathophysiology. So how is the difference? For example, like complete occlusions or partial occlusions. Okay. And that's one thing. And sign and symptoms too, I think you guys covered already. And in terms of investigations, I think you need to appreciate everything baseline, blood tests, and so on. And in terms of management, I think management we just focus on a few points. The common one, the acute one, that will be morphine, oxygens, and antiplatelet such as aspirin, clopidogrel, and anticoagulations. And the specific management, that's when you're talking about angiography. And I think just be aware about the angiography and angioplasty. And subsequently, for special management for STEMI, slightly different. Do you have to mention about primary coronary interventions or fibrinolytic agents? Complications, I think we can ask, but not that in details. And ECG, usually we won't ask about ECG because ECG, I think, is a bit complex. Okay, ada apa-apa soalan? Tak ada, ah? So far, we have, I didn't expect to finish quite fast, half an hour. So, ada apa-apa lagi soalan? Tak ada, ah? If tak ada, then I think we just let me see whether I have another one slide that I can show to you. Okay, boleh nampak ke slide ni?
Boleh.
Boleh, eh? Okay, this one, just to show lah sample of questions that we tend to submit to ni lah, medical students. But I think for nursing students, or I think you guys dental ke nursing, eh?
Dental.
Dental, okay. I think the dental student we try to do is slightly different, but this is almost the question that we tend to ask now for medical students. But for you guys, I think we try to tone down a bit. Okay, so again, this is just to highlight the symptoms of how does it difference in terms of chest pain. Because chest pain, as already mentioned, it can be a lot of things. It can be due to GI, it can be due to respiratory. So the question number one, everyone can see again. Tall, thin man, right-sided pleurotic chest pain. So what will be your differentials? What will be your diagnosis? Can anyone answer that? Boleh ke? Okay lah. So this one just to highlight, tall and thin. When they have a tall and a thin, there's always a risk factor for pneumothorax lah. Okay. And second one, obese lady, recurrent chest pain at night. So when we have obese lady, recurrent chest pain, usually obese lady is a predisposing factors for GERD. So this especially they can have chest symptom at night lah, GERD. So the answer will be GERD. Number 3, postpartum chest pain. Anyone know? So this one actually is pulmonary embolism lah. So when the patient have chest pain, not just it cannot eat. Okay, never mind. We go through one by one. I think this one is ES and this one pneumonia lah. Okay. So when a patient have fever, they can have pleurotic chest pain. Then this is pneumonia. Okay. So from this, I just want to highlight that symptom of chest pain. Sometimes they can come up with one best answer, for example, like that. Patients and then came with symptoms, chest pain, for example, and then what will be the diagnosis? So just to highlight, this is commonly that we tend to ask, but we try to tone down the severity, the difficulty levels. For example, this actually is sent for final year, I think. So the key point, we definitely for the question, they always have key points. For example, when you talk about postpartum, especially patients with post-delivery, the areas of having thromboembolic event. So that's why pulmonary embolism is one of the answer. Okay. Pneumonia, they tend to have pleurotic chest pain, but they have to have fever, cough, So think about pneumonia. And ACS patients, usually when they talk about ACS, they have a lot of comorbid lah. Type 2 diabetes, hypertension, smoking, semua tu. Okay. Okay, ada apa-apa ni? Yeah. Kalau if tak ada apa-apa, then I think maybe I just call a day lah. Okay. Ada soalan ke apa ke before we finish, before we conclude? Ada ke? Tak ada soalan ke? If tak ada, then I think I just going to call a day lah.
Okay then.
Tak ada kan? Okay, okay. Okay. Thank you. Assalamualaikum.
Waalaikumsalam.
Thank you, doktor.
Thank you, doktor.
Thank you, doktor.
Thank you.